Hello, welcome to the second part of the video for the complex wound dressings. Now we're going to talk about dressing change. You guys have already done the simple wound dressing, have done, probably some of you have performed a procedure in the clinical area as well. So can you guys think about why do you think we need to change the dressing? What could be the wound care goals? So just uh, quickly pause the video and see if you can come up with what could be the goals of the wound care. So we need to do a wound dressing so we can provide in a wound environment that supports healing with an appropriate topical dressing that could be removing an infection, giving some hydration. We might need to do an assessment of the wound and of a peri-wound skin. We have previously talked about the peri-wound skin is this area 4 to 5 centimeter of area around the wound, and choose a wound dressing that meets the characteristics of a wound bed. Suppose wound needs in a moist environment, so you might do a saline soak. So we will discuss the saline soak a little bit further. So there are different types of dressings, depends on the need. So the first one you have probably seen is a gauze. It's a simple, it could be polyester gauze, it could be cotton-based gauze. Next is the transparent film. It's called a Tegaderm. In the clinicals, you will see. Next is the non-adherent contact layer. In the clinical, it comes with a name like an Adaptic. So it is a Vaseline impregnated gauze. Next is the foam. It is a little cushion type dressing. It is there, you might see in clinical as like a name as Biofoam or a biotin. It can absorb some drainage, and it can also provide protection so to the bony prominences as well. And next is the hydrocolloid dressing. It comes in a different shapes based we need to use in the area. So there are they could be clear or looks like a skin color, like skin color dressings called duoderm. There could be another clinical trade names as well. So, and then there is an alginate. So these are they're usually sorry, they could be silver alginate, calcium alginate. You need an order to use this dressing. You cannot just go ahead and just put on any dressing. And next is an hydrogel. It's an intrasite. It is an um, it is usually used for a debridement. And next is an antimicrobial. It could be iodine based, it could be silver based, depends. You also need an odor. So to use gauze, transparent, foam, uh, non-adherent, and hydrocolloid, sorry, you do not need a physician order. Based on your nursing judgment, you can use it. But intrasite, antimicrobial dressings, and alginate, you do need a physician's order. Next is how we need to prepare. First and foremost thing, as we all know, once you're done panicking, please check your orders. Uh, Once you check the orders, what do you need? So you need to prepare the patient. It could be informing a patient that you're going to do a dressing change and to see if the patient needs an analgesic and make sure the patient is in a comfortable position. And the second is you need to gather supplies, like, and it could be dressing tray, gauze to clean. You might need a syringe or anti-cat if the irrigation wound is ordered. You need a sterile gloves, dressing material, like we talked about. You probably need an intricide or some antimicrobial or alginate dressings. And then at the end, you need a tape or any securing device. You can use a meat core, you can use a paper tape or Montgomery ties, whatever the you can see, like the top, securing device you will use based on the nursing assessment. And I'm not going to talk about how to do a dressing because it is very similar to your simple wound dressings. It's just you will use a sterile technique instead of like a clean or aseptic technique in the complex wounds. So there are some key differences in the complex dressing and a simple dressing we'll talk about. So sterile, it's a complex dressing is a sterile procedure, and whereas a simple is an aseptic procedure. And complex wounds, the wound is typically open, and whereas in simple dressing, the wound is usually closed. It could be incision or anything, but in this, the wound are open, and there could be undermining or anything. There is a requirement that you need to do a wound bed assessment. You need to see what does it look. Does it look pink, granulated? Is it a black or like there's presence of slough. Whereas in a simple dressing, you only need to check how does incision look, like if the edges are well approximated or not. In both dressings, we always clean from most to the least contaminated area. It is so this principle stays the same in both complex and the simple dressing. And the product that we use, we need to change depending on the assessment and based on the order. So sometimes doctor might order dressing every 6 hours, or it could be we need to leave the dressing on for 2 days. So it depends on the physician's order and based on assessment as well. If doctor ordered for 2 days, but your dressing is visually soiled or it's coming off, then you need to either reinforce the dressing or you need to redo the dressing. Whereas in the simple dressing, it's usually used gauze or non-adherent contact layer that I have already shown you in a previous slide, like an adaptic. In a complex dressing, it's common to use like we might need to irrigate the wound or pack on a wound with antimicrobial or the silver nitrate, or silver alginate. Whereas in a simple dressing, these dressings are superficial. We just like put a simple either gauze or non-adherent contact layer and we skewer it. Next, let's talk about wound irrigation. So wound irrigation is the steady flow of a solution across an open wound surface, usually to achieve wound hydration, to remove deeper debris, and to assist with a visual examination. The main idea for the irrigation solution is to remove cellular debris and surface pathogens that contained in the wound, exudate, or residual from topically applied wound care products. So suppose you have applied lots of intrasite gel and it's excuse me, it's painful to swab or just like wipe with gauze. So there might be we might use an irrigation. Normal saline is the most frequently used irrigated, but a physician may order different solutions as well based on the wound assessment. And pressure is the key to the effective irrigation. Too little, excuse me, Too little pressure will fail to remove the surface bacteria, which may lead to the wound infection, but too much pressure can actually force surface bacteria into the wound bed, in addition to damaging the like in a new granulating tissue. So you have to be very careful the amount of pressure you use. And we should be careful to allow the solution to flow from the cleanest to the dirtiest area of the wound. And do not force irrigate solution into any like a wound pockets if there's a tunneling or there is undermining. So you do not force to gently flush or irrigate the areas of a tunneling. Um, so now, if there is a wound packing, if your wound needs to be packed, what do you need to do? So first and foremost thing you will do is you need to assess and measure the size, depth, and the shape of the wound and record your findings. You can use a measuring tape for this. Uh, the other thing you could do is when you take the dressing out, you will see how much dressing is taken out. So that gives you an idea how much and what type of a dressing will go in. So you need to assess for tunneling and undermining and check if you need to pack any undermining. Do not pack too loose or too tight, because if you are packing it too tight, there is no um, and you're not leaving any place for the tissue to granulate. And if you're packing it too loose, then the packing would not serve the purpose of extracting the exudate. And use saline soap. So that's the most commonly used dressing you will see in the clinical area. The gauze are available in a different lengths and width, so you have to use a nursing judgment to select the size of the gauze based on the size of the wound. So, and the very important thing is do not use multiple small pieces. If there is suppose there is an undermining, so do not use small pieces because that could you can miss the piece and it could get lost in the large wounds. So try using one single piece if you think your dressing you need lots of packing and you do not have enough. You can tie two gauze together to make a one strip, and make sure you chart how many pieces you used. Next is a wound debridement. Previously, we discussed the presence of yellow slough or black scar over the wound that hinder the wound healing. So to remove the slough or a scar, there are different debridement methods used in the clinical area. First is autolytic methods. Autolytic debridement is the removal of necrotic debris and devitalized tissues from a wound through a moist environment that facilitates the wound's own endogenous enzymes. It is a conservative and comfortable approach and may take a long time to work. We have previously discussed about the intrasite gels or the hydrogels. These are used as an autolytic agents. Next is enzymatic or collagenase. It is performed by the application of a prescribed topical agent that chemically liquefies necrotic tissue with enzyme. These enzymes dissolve and engulf dead tissue within the wound. Next is a biological. Um, I have seen personally only once this is done. So it is the use of the maggots. The maggots are like usually green bottle fly larvae that are grown in a sterile environment and digest dead tissue and pathogens. The sterile maggots are applied to the wound bed with a dressing used to confine the maggots to the wound. These are the custom and pre-assembled dressings available, as well as the option to create your own. As a nurses, it is not in our scope of practice to design dressings, and you do need a training to do the biological debridement. You have to do a little course to get certified. before you can perform this kind of a dressing. Next is the mechanical. It is by irrigation, hydrotherapy, or wet to dry dressing. It is a mechanical, the saline soap gauze is considered a mechanical debridement. So this technique is cost effective but can damage healthy tissue and is usually painful. This type of a dressing is used to remove drainage and a dead tissue from the wounds. A wet to moist dressing is another option accepted in a long-term care. This type of dressing is used to promote moist wound healing and is used to remove drainage and dead tissue from the wound. Deep wounds with undermining and tunneling need to be packed loosely. Without packing, the space may close off to form a pocket and not heal leading, which may lead to the infection or the formation of abscess. This type of dressing is to be changed daily compared to wet to dry dressing, which is changed every 4 to 6 hours. So it depends on the type of the dressing. There is which I already talked about, the saline soap dressing is depend on the how much drainage is coming. So you might need to change every 4 to 6 hours based on the physician order, or there's another method that is like a wet to moist dressing as well. And the next is the sharp dressing. So it is important to remember autolytic, enzymatic, and mechanical debridement. These can be done or ordered by the wound care nurse in the clinical area, whereas biological and sharp debridements has to be ordered by the physician. But sharp debridement is only done by the physicians. So it is performed by a skilled practitioner using surgical instruments such as scalpel, curette, scissors, and forceps. This debridement type promotes wound healing by removing biofilm and dead tissue. The level of debridement is determined by the level of a dead tissue removal. Surgical debridement is the most aggressive type of debridement and is performed in a surgical operating room. Sharp and conservative debridement can be performed in a clinical or at the bedside with the sterile instruments. It is important to remember this cannot be done by the nurses. All above four, autolytic, enzymatic, biological, mechanical, we can perform the procedure based on the order, but sharp debridement, we cannot do that. So this is like a little bit wound bed treatment strategy plan called DIMES. So I'm not going to go over whatever we have talked about the dressings. Everything is covered. So some clinical area will have this. So you can print it and keep it in your pockets. It will be good reference source for you guys. If you see a dressing, you can see what kind of what your goal is and what kind of a dressing you probably need for a particular type of a wound. Next is the negative pressure wound therapy. It is also called as a wound vac. Um, some of you probably have encountered in the clinical area that it's black or blue looking foam with the little suction on it. So this is called a vacuum assisted wound closure. It refers to the wound dressing system that continuously or intermittently applies subatmospheric pressure to the system, which provides a positive pressure to the surface of a wound. It has become a popular treatment modality for the management of many acute and chronic wounds because the wound, when we leave it open, do a saline soap dressing that heals in a month, it can rapid. It can increase the speed of a healing. by optimizing the blood flow in the wound bed, and it decreases the local tissue and swelling. And you do not, like a wound, sorry, like a saline soap dressing, you do not need to change it every day. It is changed either every other day or every second day based on the odors. So it removes the excessive fluid that can slow cell growth and proliferation in the wound bed. It decreases the number of bacteria. Additionally, the intermittent low pressure alters the structure of the cells in the wound, which trigger a cascade of intracellular signals that increase the rate of a cell division and the formation of a granulation tissue. In the clinical area, if your patient has a wound vac and you are to do the dressing, make sure you ask for this direct supervision from the instructor. These dressings usually take 45 to an hour, even for the experienced nurses who has done it for numerous times. So if you have a chance to look at it, to be a part of the team when they do the dressing, it would be a great opportunity to do it. But try to have a direct supervision when you actually do it too. Next is the wound culture. Wound culture is a test to find the microorganisms. It could be anything, bacterial or fungus that can cause an infection. So when you do a swab culture, it is the most common technique used because it is non-invasive and most cost-effective as well. This type of a culture will usually identify the bacterial species of the infection and help steer an antibiotic therapy in the clinical area. So please be aware that surface swabs will only unveil the colonizing organism and may not reflect the deeper tissue infection. So how to take a swab? It is important before you take a swab, you clean the wound with a normal saline and a pad dry wound bed with a sterile gauze, and try to culture the healthiest looking tissue. So if your wound is yellow, there is some red part on it, so try like applying a sterile applicator over the wound for 5 minutes. Like try to kind of like so you can actually have the some like some stuff on the, if there's a presence of bacteria, you can collect the bacteria on the tip of the applicator. And if the patient has multiple wounds, please use a separate swab for each wound and label it. Labeling is a must. If you send a swab to a lab and did not label your whole procedure, you have to redo the procedure. Next is the documentation, the most important part. If you did not do a document, it means it's not done. So what you need to document once you finish the dressing, it is important to see, because it's one of the R's as well, right documentation. Most of the clinical sites use wound assessment sheets, but if no, separate sheet is available. You can do a longhand charting as well. So your charting should include the time of the dressing, location of the wound, what packing or dressing you removed, and how many pieces you removed. Measurement of the wound, that includes depth, length, width, presence of undermining or a tunneling, description of the wound bed color, surrounding skin or the peri area, presence of odor, if any, and amount of the drainage, if present. Amount of the drainage, is it scant, is it large, moderate, and what type of a solution you used. And then was the wound packed? If yes, what and how many pieces you used, and what external dressing you used, and how patient tolerated the procedure. Another thing you need to mention if the patient was given analgesic prior to the dressing change or after the dressing change. And that is it. So please go to the e-class and see if and there is one video that you guys need to do. And also I have attached the wound care sheet, um, there's a scenario sheet that worksheet you need to complete, and please complete your knowledge checks. Thank you.